and offer hands-on training, online workshops, and international webinars for clinicians interested in an integrative approach for mental health. Thank you, Mirjana. Take it away.
Thank you, Nia. And thank you, everyone, for having this opportunity to talk about ANFI. And I'll give you a little bit of a story of how ANFI came about. So our origins are, we are part of New South Wales Service for the Treatment and Rehabilitation of Torture and Trauma Survivors. You've heard Shayla talking about our work with clients. We work with torture survivors, and our Australian Neurofeedback Institute is one of START's programs. START's decided to find a way to continue to fund neurofeedback program. We don't have a specific funding at this moment. So our funding comes from internal fee for services, and we would like to continue to provide neurofeedback and EEG assessments to our clients who can't afford these services otherwise. And ANFI, as Australian Neurofeedback Institute, came from that idea. If we can provide training, mentoring to other clinicians in the field, that can then help us supplement our services and continue to provide neurofeedback to our clients at STARTS. We work with clients with complex trauma experiences. And our training and mentoring that we are offering is based on our experience in working with this client group. What we are aiming to do and what we would like to do is to actually develop a network, collaborative network of clinicians who work in the field of trauma, who are keen to use neurofeedback and other neuromodulation modalities, and to keep developing and expanding that knowledge, experience, and expertise, and offer so that other services, other clinicians can offer these services to their clients. We are very keen on research, and some of our trainings that we provide through ANFI is based on our research that is done at STARTS. At this moment, we have 3 research projects that are running. One relates to efficacy of neurofeedback for PTSD. This is done in partnership with University of Sydney and Westmead Institute for Medical Research. We are also interested in, we are already using SSP program, Safe and Sound Protocol. Porges has also agreed to support our pilot research study in using SSP in working with children with trauma. And this will be also done in partnership with University of Sydney. And our third research study relates to finding neurophysiological markers for PTSD. And for that project, we are using machine learning. This is done in partnership with Macquarie University. And I'm telling you this just to give you the idea that through our clinical work, we also, as part of what we do, is to provide evidence of interventions that we use at STARTS. And these 3 projects are our main projects at this moment. We are really interested in providing training and mentoring to services that work with trauma. We have, at this moment, certified introductory neurofeedback training. It's BCAA certified. That we provide. As part of that is done through self-paced learning. We have a learning platform that we use so that you can access it in your own time. And part of that is at this moment done through Zoom training. And we hope from next year we can go back to face-to-face training, because nothing is better when you're doing your practicum than to sit together with other clinicians and practice neurofeedback together. We are also certified to provide BCAA, heart rate variability biofeedback training and mentoring, and we are developing our training package now that we will probably start to provide from next year. Apart from these 2 main trainings that we are offering, we are also inviting other clinicians that have been working in the field of neurofeedback for many years. And I will tell you a little bit later who are our next guest speakers. The training and webinars that we are providing are geared towards clinicians that work with clients who had trauma in their background. So having said that, in many other areas of work, we can find actually that there is trauma that is linked to symptoms that clients have. Is it ADHD? Is it psychosis? So this is actually often trauma is in background of many other presentations that we might see in our practices. So I really believe that this is not just narrow focus on trauma, that actually can help clinicians in other fields to develop their practices, to learn from other clinicians in the field. And that can be our avenue of learning, growing together. Apart from neurofeedback training and mentoring, we are also offering EEG assessment. We are also providing personalized EEG reports. Each of our reports is seen by our EEG analyst. Report is then written based on client symptoms with recommendations for neurofeedback treatment. Also, what we are very keen to do is to offer support to clinicians in the field. So we are in the process of developing our neurofeedback community through ANFI to offer membership, access to our free webinars, also way of connecting with our colleagues in the field and share our experiences. So these are trainings that we are offering now related to neurofeedback, other neuromodulation techniques in working with trauma, heart rate variability biofeedback, quantitative EEG, and impact of trauma on brain. Through our research projects and through our data collection, we actually learn over time. And Shayla mentioned we've been using EEG in our work since 2010. We've been supervised by Jay Gunkelman for many years. And what we realize is that some patterns that we can see in EEG are repeatedly seen across different ages and different client symptoms. And we would like to share our experience with you and talk about that in one of our trainings. Probably we'll organize one early next year. Also, we use in our work event-related potentials, and we use them for research studies. We hope that we'll be able to share with you soon some of our new findings. We find that a use of ERPs is really important for important measure for pre to post treatment. And we hope to continue our collaboration with Yuri Kropotov. So these are some of our trainings that we plan for this year. 15th of October, we have training, the webinar that Shayla will run on use of heart rate variability biofeedback in clinical practice. Then on 28th and 29th of October, we have neurofeedback in clinical practice training for clinicians. On 5th of November, for those who work with children, we have enhancing regulation in children through sensory and neuromodulation webinar done by Anna Morel. Anna Morel is a clinician from US. She worked for many years in a Harvard trauma clinic. She's a very skilled clinician. She has been using neurofeedback for many years, and she's combining a lot of different modalities in her work. She will focus this presentation on talking about sensory and neuromodulation. And then on 12th of November, we will have Ed Hamlin, who will talk about use of neurofeedback in treatment of eating disorder. Recently, we had a great webinar that Ed presented for us on use of thresholding. For those who didn't have a chance to see that webinar, you can still access a link to find and purchase this webinar on our ANFI website. We will give you at the end our website address. And it's really great. It was a great webinar as he was talking about understanding how through use of eager system, because that's the system that he uses, and using different ways of thresholding, reward, and inhibit bands, how you can enhance treatment outcomes. We all enjoyed his presentation, and we are really lucky that he also accepted to come back and talk about eating disorders. That is his area of expertise. At Tanfi, we are also offering mentoring program, and we really encourage clinicians who had their initial training in neurofeedback to access supervisors immediately after, so that they start to use neurofeedback while they have still that fresh knowledge from what they learned from training. Our training is, as I already said, geared more towards clinicians who work with trauma. And what we are offering as part of our mentoring package is case presentations, discussion of your personal training. We are following BCIA curriculum of what is necessary in terms of further training and mentoring for you to then sit for BCIA exam and get recognized as neurofeedback clinician who is BCIA certified. We are also going through detailed case studies with you, and also you will have an opportunity to sit with one of our mentors, and we will share our case studies, the way how Shayla did today, in how we work with clients with different presentations, and how we combine neurofeedback, psychotherapy, and other interventions. Part of one of the requirements for BCIA certification is to have direct observation of client work, and we can offer that as well. We are offering either work in small groups, up to 3 clinicians, so that everyone has a chance to share their cases, to discuss the cases with us, and also to learn from each other. We can also provide individual mentoring sessions. For quantitative EEG, we have EEG clinic that is based in Fairfield in Liverpool, where you can send your clients. If you don't have opportunity to conduct EEG yourself and you live in Sydney, we require referrals, so we are not accepting clients who self-refer for EEG assessment, but if they are referred by neurofeedback clinicians, we can conduct QEEG assessment and provide for you full QEEG report. Our lovely EEG analyst, Darius Roundtree, is really committed to this work. He's full-time with us, and all his work goes into learning to interpret EEGs, and together with us, he's learning how to connect what we see in EEG with clients' clinical presentation, and based on knowledge and experience that we have in treating our clients, to decide on possible neurofeedback protocols that you can use in your practice. But what we are really hoping to achieve with ANFI is to help us link clinicians together and learn from each other. What we are offering at the end of the year, we'll have a special guest. So we are starting now a series of webinars called Stories Worth Telling. Every month, we will invite one of our colleagues who spent years in doing neurofeedback or EEG assessments, serving their clients. We will invite them to share their story with us. What we believe, it's very important for us to share what we know, but also to cherish each other. This is pioneering work that we were all doing. And it's important that we recognize work of every single person that worked with us in Australia and internationally. Our first guest speaker is Rob Bushkins. He's one of the first neurofeedback practitioners in Australia who taught and mentored many of our clinicians. This will be really informal gathering. It's free of charge, where we can all sit together after working hours at 6 p.m., have a dinner together, glass of wine or margarita and listen to our guest speaker's story. Rob's story is very interesting, the way how he started and the reasons why he entered into this field. He will talk about that, and he will also talk about use of alpha theta training in his work with clients with PTSD and addiction. I really believe that his story is worth to tell and for us to hear as well. And then next month, we will tell you who will be our next speaker next year in January. This is just part of our team. So we work hard, but also we like to have fun. And I think it's very important for all of us to remember that, not to forget ourselves. It's not to take us too seriously all the time, to have time to reach to each other, talk to each other, spend time together. And we hope that through Amphi, you'll be able to get some of that feeling of being welcome to a community of clinicians, where everyone's skills, expertise are welcome. We are keen to share, we like to share our work, and we also like to hear from you.
Thank you, Mirjana.
This is our address. This is how you can reach us.
Thank you. I don't know if people want to ask a question, so we're gonna move to our next speaker who I've reached. Moshe, I don't know if you are around. There's Moshe. Fantastic. Thank you, Mirjana. Thanks for that. I'm very partial, so I'm not gonna say anything anymore. But it is my pleasure to introduce next speaker, the legend in the field of neurofeedback, Dr. Moshe Perl, who's many things. He's a clinical psychologist, psychomy, body-centered psychotherapist, BCN certified, QEG diplomat. Probably there's more stuff, but you know. And he's been practitioner of neurofeedback for the last 20 years. Moshe has successfully treated over 1,000 clients with a variety of issues with neurofeedback, and his expertise has been broadened by the vast number of cases he has discussed through mentoring and teaching of hundreds of professionals. Moshe has learned from many of the recognized world-leading experts in neurofeedback and EEG, and distilled that knowledge to apply to his own practice and to share it with his students. So Moshe will tell us today, talk about chronic pain. Thank you very much, Moshe, and welcome.
Thank you, thank you. The big boots to fill there. Can I share my screen at this point?
Yes.
Let's see, all right. You should be.
You're ready to go, Moshe.
Okay, you should be seeing, yes, all right.
Venice, yeah.
Venice, there we go, all right. So now let me do what I did before and see if I can just, yeah. So,
if you go at the bottom, Moshe, at the bottom right, there is that little thing, you know, with a little square and thing sticking out of it. That's the full present. Next one, one more. That's the one.
thank you. There you go.
And if you go at the top, there's display settings, so you can display the full screen instead of presenters. So display settings up on the left. Next one. Yep, click that. And it says the swap. Yep. There you go.
There you
Brilliant.
go. Oh, thank you.
And
okay. Thank you for that lovely introduction. Thank you to ANSA for inviting me to speak. Today we're going to do a protocol forum, which is really not so much about what I have to share with you, but what you guys have to share with me. And I've chosen the topic of chronic pain because chronic pain is so complex. There are so many causes, And as a result, there are so many different ways that we've seen to work with it. And I know a few of those ways, but many of you will know other ways as well. So I'm interested in us sharing that. So I just want to start with a few slides before we get going with actually a discussion. The first question is the work of clinicians scientific? It's as if the only science we have is what researchers give us, and what we do is just sort of, oh yeah, so you did this, so you did this. Well, of course our work is scientific because we're scientists, and we're looking at what works and what doesn't work. Okay, so the next thought is when independent experts discuss an issue. If you take all their answers and then you divide by the number of experts, you get the average. That is probably the best solution. In other words, the solution is the commonality in the findings that you see when experts talk. And we are experts, some a bit more, some a bit less, but we all have worked with neurofeedback. We all know stuff. So we're all experts. And when we talk about stuff, the sum of what we talk about is the answer to the questions. What about scientific studies? Okay, training, let's say FZ minus A1 and rewarding 15 to 18 hertz versus training C3 minus A1, rewarding 15 to 18 hertz. Both have been found effective in increasing mood and focus. So which is better? Well, there'll never be a study that investigates that relative efficacy. It's never going to happen. When and how one protocol might be better is an interesting question. Is FZ minus A1 better for certain things than C3 minus A1? The only answer to that we're ever going to get is if clinicians talk about it. There will never be a study on that. Is our preference for one over the other a result of a true difference? Maybe it's true for certain subtypes of the issue we are dealing with. Maybe it's a result of our own history with this protocol. We tried something, it worked, so we just keep doing it. And we can become superstitious about our methods. You know, I do it this way. No, the other methods don't work, whatever. So the thought here is, let's become inclusive, and that's a message for me because I tend to be very closed sometimes about stuff, except that there may be many solutions to any training issue. And why might that be? Any neurofeedback in the brain makes a demand on the brain to self-regulate better. What does it take to get that right? Could we put sensors anywhere and train any old how and get a good result? I wish. Is this just the placebo? I think we all know from experience that any protocol at any site on the scalp doesn't necessarily work. It's very sad, but it's the way it is. And then, of course, wouldn't it be nice if each training site on the brain represented access to discrete brain functions? In other words, C3 does this, T3 does this, T5 does this. If you want to deal with it, just train there. Just learn the function of each site and then train. Neurofeedback would be so easy. Not. That's not the way it is. Any site on the brain is a possible access point into a myriad of brain networks that pass through that point. We are now at a place where we understand that there are just networks everywhere. We talk about hubs, all of that, we're getting that. Now, whether or not the spot we've chosen is an access point may depend on what frequencies we're using, which may be rewards or inhibits. So we don't necessarily know that. It may also be a network that's open to change or not. We don't know. And how many networks are there in the brain? Thousands, millions? We don't know the answer to that. So work is being done to understand how multiple networks can pass through one area of the brain without disrupting each other. And I always like to think of the Tokyo train station that has 7 levels, and each level has about 24 platforms. Just imagine getting to the right station, to the right platform at the right time to catch your train. That's what information in the movement is, information in the brain is like. In other words, the information has to get the right place at the right time. But it also brings up the question, you know, we know that FZ is a huge focus. It's a huge hub, just like CZ or underneath CZ and PZ. So how does the brain figure out one network not interfering with another one? How does it do that? And, you know, people are asking these questions. Once we know that, I think we can figure out how to target the network better. But right now, we don't have that sort of information. But we do have certain information. We have a large body of clinical experience that gives us direction. We know that we can reliably influence the brain for good with certain training protocols. We guess at what the underlying networks involved might be. We have theories, fantasies, and superstitions about what is actually taking place. I always tell folks that when a psychologist has a theory about why something is going on in the brain, you go, okay, that's all right to have the theory, but we know that in reality it won't be true. But it doesn't matter, because whatever theory we're going to have is going to be hopelessly simplistic. There's a quote once where one of the old stages in neurofeedback said, you know, if our brain was simple enough to understand, we'd be too simple to understand it. In other words, the brain is just going to be very complicated. But if we have a theory and the theory leads to some good outcomes and gives a direction to R&D, to research and development, then it's a good theory. So, to our endeavor, how can we help people who suffer from chronic pain? I throw it open to you to just start sharing. Tell us about your experiences with this, and I'll stop sharing my screen now, or if you can get me to stop sharing so we can just see each other and chat. And I promise you, I'm going to be taking notes. So please, somebody tell us something about chronic pain. It might be a question, it might be something that you've done, whether it worked or it didn't work. I'm interested. And chronic pain can also include, I just spotted you, Martin, it can include migraine. Who has a thought?
Terry here, Moshe.
Terry.
Hello.
Hi.
My favourite protocol is not necessarily neurofeedback, but
go for it. When you're a modulator here.
Transcranial direct current stimulation.
All right. Give us some thoughts on it.
Well, there are, with TDCS, there are a number of different protocols, a number of different sites to place electrodes. So anxiety and depression, for example, there'd be a placement on the prefrontal cortex. For chronic pain, a placement I use is back basically over C3. And I've had some very successful results with TDCS and chronic pain.
C3.
With a number of clients, yeah.
Anode, cathode?
Anode, anode over on C3. The cathode I use on the back of the neck. I'd like to get it away from the brain. If you read a number of research articles on TDCS, they put the cathode on the head somewhere, but I like to get it right away from the brain and put it on the upper back.
Okay. And any kind of pain you work at C3, or is it specific kinds of pain you've seen?
No, just whatever it is. Yeah. I guess one of the most successful was a guy who had a car accident when he was 13-year-old and had chronic pain in his lower right back and his right shoulder. And he was on OxyContin, and that didn't seem to be working too well for him either. And I actually did DC stimulation twice a day for 5 days, and at the end of the week he didn't need his OxyContin anymore.
Sweet. Yeah.
Quite a powerful intervention.
Yeah. Sweet. Thank you. Anybody got any thoughts about that? You're free to ask Terry more about it, or you can offer something else.
Can I just speak, or I've unmuted myself? Is that right? Yeah. I would agree with Terry. I've just worked for the last 3 years at the Northern Pain Centre at Ronald Shaw Hospital. And people can see, there we are. And I would agree with that. And I also use Nick Dogris's, pulse magnetic frequencies, and also the 19-channel QEG training from Bob Thatcher's program, and I find that very, very powerful. And it's lovely to do, an initial QEG map, and then do a range of treatments, including, deep relaxation, hypnosis, mindfulness, EMDR, and also the anxiety release program from Mark Grant's program is really, really powerful and portable. I like the patients taking away portable programs. Most things can be recorded on the iPhone. And then afterwards you do regular sort of follow-up assessments via QEG, and you can see the change in the dysregulation in the brain maps. And I find that really, really encouraging. And the only problem is that when you're doing this, you're sort of the only gay in the village, no one else is doing this, and most people are doing CBT, you see. And the insurance companies are not necessarily aware of what I'm doing, but I always say it's cognitive behavior therapy. It's really operant conditioning coupled with dynamic psychotherapy. So it's a whole range of tailored approaches to the individual patient. It has to be so individualized. So there's not, as you say, there's not just one protocol. You have to use all of your therapy skills to initially develop a very, very sensitive and good rapport with the patient, particularly with chronic pain. And these chronic pain patients are usually dosed to the eyeballs with psychotropic medications, and a lot of them don't like those medications and go off those medications. So you've got people withdrawing from medications as well. So you're dealing with that. And but you can, if you're very patient, I find that most patients really develop a whole lot of important and powerful self-regulation sort of techniques and skills and protocols. And that's what you're really working with all the time. And so it's that regular, sensitive and tailored approach is very, very powerful. I would probably say that now that initially I was very anti pure cognitive behavior therapy, but I would say nearly any therapy will work as long as it's sensitive and it allows growth and adaptation throughout the process. But the wonderful thing about neurofeedback, of course, is that we can show evidence, scientific evidence-based change in the brain. When symptoms disappear, you see a better brain map.
Question for you, Marianne. First of all, on the EEGs themselves, do you see any patterns that seem to show up more often than not?
in some cases, but it's still, I find it's still highly individual, but there's certainly over time, as the symptoms improve, the dysregulations improve.
Yeah,
as well.
I'm interested in what the patterns of dysregulation look like. That's what I'm interested in knowing.
Yes, look, it depends, because, you know, it depends where in the body the pain is mainly. So you have a whole range of chronic pain situations. You have neck pain, shoulder pain, abdominal pain, fibromyalgia.
Okay, fibro. How does fibro show up in a queue?
It varies depending on the pain level too. Some people's pain levels will vary, and some people's pain levels seem to be consistent. So you're going to see sort of different dysregulations. And when you have a flare-up, you certainly see a lot of more frontal lobe, then you see more temporal lobe in the flare-ups. With a lot of the chronic back pains, you actually see a lot in the occipital lobe. But it'll vary. That's the unfortunate thing, that it's not a standard dysregulation that you're going to see. I see so many different patients, and some have medications on board as well. So I've not been able to collect enough data to say, well, all fibromyalgia looks like this and all neck pains look like that, because there's so many other medications involved, physiotherapy, chiropractic, acupuncture, all of these things, massive sleep disturbance, which really affects the brain.
Oh, great. Okay. Yeah, anybody else see any sort of pattern showing up, either from EEG work or from neurofeedback work, in terms of what they're seeing?
Yeah, Moshe, we've seen sharp and slow transients temporarily, T3, T4, T5, T6, and that's the most consistent pattern that we see. And one of the most persistent symptoms that our clients have is headache. Many of them diagnosed with migraines. And we did see that T3, T4 training in many of these cases they would respond well, and not for everyone. For some clients with migraines, it can work really well.
Okay. Okay. So, and the sort of chronic pain that you guys see, I mean, you talk headache. I guess with trauma patients, you would also be seeing chronic regional pain, fibromyalgia.
Yes.
Also, from war-torn countries, you would see head traumas.
Yes, and also body pain that relates to torture experiences.
Okay.
And some of that is actually, as Marianne said, some of that is work with neurofeedback, and a lot of that is actually looking at what that pain represents. Because often trauma that is locked in a body, you can actually work with much better if you understand and your client understands what is body trying to tell it.
Give me an example.
For example, someone who is complaining of constant shoulder pain on one side and difficulties in moving hand. It could be related to experience that they had when they couldn't, for example, protect their child, the way how they were trying to reach and they couldn't. And that pain is telling us the whole story of what happened. I was unable to reach my child and help my child who was killed in front of me. So you could have a pain in chest pain, often comes with grief. And sometimes it is about allowing yourself to grieve.
Mm.
So it's not necessarily that each time is neurofeedback that you will do.
Yeah. So I guess what you and Mariana are saying is that there's a story here. And the story needs to be told and heard.
Yes.
Okay. And that's obviously one of the complexities. When you train at T3 minus T4, now we had a conversation about this a little while ago, and yeah, tell us a little bit more about the T3 minus T4 and what you saw, and what are the rewards, what are the inhibits that you end up with?
Mm-hmm. Often is what we see transients are somewhere in alpha range. So the most frequently we would train 12 to 15 or around somewhere in that range. Not, again, it's not everyone would respond well to these frequencies. And sometimes with clients with migraine, but more with clients with fibromyalgia, although I have to say we didn't have a huge success with fibromyalgia, with some cases we did, was actually training simultaneously 8 to 11 and 12 to 15 hertz. And that's one of the protocols that we heard from Ed Jacobs. And it did show good results for some of our most complex cases. Also, with this type of fibromyalgia cases, we are really very cautious about duration of the treatment. So sessions are really brief.
What are we talking about?
Few minutes.
2 minutes, 3 minutes, 5 minutes?
Yes, few minutes. And then if you can keep expanding, but really brief initially. That's what we did. But I have to say that in many cases, we didn't have actually good, we couldn't find a good protocol for fibromyalgia. And there was one particular client who responded reasonably well, but then I sent her to Dana, and Dana did wonders with NeuroGuide. So sorry, Dana, I can see you here. So I think that you can tell us also about your protocols, because for that client, that was really someone with years of chronic pain, and Dana did wonders with her.
Dana.
Unmute myself. Okay. Well, I can't remember which client was it, but I do work with chronic pain often, and I absolutely have to join Marianne. They differ, and you really have to look. First of all, look whatever you learned anyway, and then look at the brain, combine it, look where is the pain, and simply use some of the protocols which are already done by research, particularly with NeuroGuard. It's very good. But then you can add your own, and you can also use TMS with neurofield. It really depends sometimes on the body. It's pretty much working with the person, the individual.
Okay.
It's not like put it on C3 and do, SMR. It works. Those things work a little, but to be more specific and get further, you really need much more complexity. Yeah.
Okay, and the complexity is not just in the neurofeedback, but in the other interventions that you're doing? I'm asking Dana.
Well, yes, of course, sometimes I have to, and if you use neurofield, it can often speed up because you prepare the brain. I'm not for that 4 seconds, these 4 minutes, I am for actually doing the neurofield for 20 minutes, for example, 15, 20 minutes, and choosing the frequencies which are good. And then the brain is almost prepared to do the neurofeedback much better and faster. So that is often one thing which I do. Sometimes the body needs help, and neurofield is very good in that. But then there's the other modifications, which I don't want to mix up over here. Yeah, photobiomodulation and so on.
Anyone else? I mean, I got my 2 cents, but that's I want to hear what you guys are doing.
Nerida, you're muted. We can't hear you.
Can I talk? Oh, sorry, Nerida. Go.
I won't take long. Look, I just want to talk about a personal experience that's happened very, very recently. I've had major spinal surgery 3 weeks ago, and I have to throw this in because it's just so important for everyone. I started doing BAUD, the BAUD, bioacoustical utilizing device, with myself the second day after surgery. I mean, the surgery was major. They've basically cut my throat and pulled everything out and worked on 4 different levels in my spine after an injury that I had years ago. And I went back to the doctor at 2 weeks, and he just said, I cannot believe how well you are going and how much pain tolerance you have, number one, but number 2, just how you're improving as a result of, he didn't know I was doing the treatment. But he said it's just remarkable. And, you know, there are about 4 surgeons involved and they're all sort of talking about how tough I am, which is quite funny. But anyway, I just think it's really important that everyone knows about that. I'm now 3.5 weeks since surgery and I'm doing things, I'm sweeping, I'm cooking, I'm working partially, building that back up slowly. So I'm very happy with that. Yeah, just so everyone.
Nerida, fantastic
Yes.
that it's happened. And tell me, what is this machine? What is this BAUD?
It's called a bioacoustical utilizing device. And the 2 things that it's renowned for, and there's quite a lot of research on it, was actually developed by, let me think, Peter Lawless, I think, and Dr. Phil, the infamous Dr. Phil. And it really is an entrainment process as well through sound, and the person adjusts the frequencies themselves according to what it feels comfortable for them. And it's a beautiful process. Yeah, that's all I can say at the moment. Yeah, and you're in control yourself of the whole sequence of dials that you have to turn to produce different sounds. And then it has an interrupter sound at the end that disrupts the frequency between both ears, if that makes sense.
Yeah. Sweet.
Sweet. Oh, very sweet. I'm very happy.
Thanks, Nerida.
A pleasure.
Sarah, you were going to say something.
Sorry, just had to unmute. I suppose I wanted to talk about my experience. I don't treat chronic pain. I work more in pediatrics, but what brought me to, you know, this modality of treatment and this community was my own experience after having tick-borne infection, being chronically ill, having like all these neurological things going on, chronic pain, migraines, just the whole bit, was seeing Marianne, and I would concur with that whole intuitive process, and that, you know, as the person's symptoms change, the treatment changes with it. And it just, you know, basically it changed me from, you know, basically not being able to hardly work at all to being back to probably not my former self, but very close to it. So yeah, just a range of treatments and just working with the person on what they're experiencing at the time. So I can't really remember what my brain maps looked like, but I think they kind of changed and morphed as we went along. So yeah.
Okay.
Cool.
And now you are a neurofeedback practitioner?
Yeah. I decided I had to have this treatment in my practice after experiencing it, because it was just so life-changing.
Terrific. That's good news. That's good news. Okay. Someone else.
If I may say
hi. Oh, sorry.
Go ahead. Go ahead.
Oh, hello, everyone. Hi, Moshe.
Hi.
I'm Katie Williams. I'm a technician, and I have returned from 20 years of chronic pain and associated injury and being unable to work or study, to being functional and working as a technician as a result of a chance encounter with a C3 protocol. So I understand that my degree of knowledge is sort of not nearly as substantial as a practitioner. And Moshe, I don't know if you've seen my queue. I think maybe you're due to have a look at it this week. I'm in southern Tasmania and we don't have access to a lot of resources there. But I have made my way through the standard options for pain, particularly C4 and anything related to calming arousal, and it really doesn't have a huge impact on, particularly for me, it's nerve pain. from a repetitive static loading injury for some reason. Standard C3 has worked incredibly well. I can only see training down of lower frequencies in my mini maps. That's the only sort of impact I can see, and that could be attributable to anything, or you know, even the variation in mini maps that are available. So I just wanted to say strange things do happen. I definitely present as needing calming protocols, and I can tolerate some of that, but it has not been nearly as impactful for me. A couple of minutes of C3 now, and I'm fine. I've got a resilience to pain. I'm sort of inoculated and able to function much better. So thank you for having me.
Well, all right. So we have a vote here for C3, and maybe Terry is going, yes, this becomes interesting.
Yeah, any feedback's fine. Happy to.
Interesting. Okay. Anyone else got something they want to add on this? And I can have a chat in a minute. I think Marianne, you wanted to say something.
I wanted to say something, yeah, because I'm a chronic pain sufferer myself, in remission from time to time. And I was sitting in one of the early neurofeedback conferences, and a lady was sitting next to me. I don't know who she was. And I had come late, and I was sitting in the back and making a buzzing sound, and she was doing it on her neck. And it was annoying me because I had neck pain and I couldn't hear what the lecturer was saying up the front. I think it was Ed Hamlin speaking to us or something like that. I really wanted to hear this. And I said, you know, what are you doing? And she said, this is the smallest neurofeedback device that exists, and you're very welcome to use it. So she put it on the table and showed me how to use it, and I used it on my neck, and I didn't believe in it. But 3 weeks later, I had this massive pain flare up. I looked through my notes. I couldn't find this lady's name or number, but I remembered the story she told me. Said this was produced for the Russian cosmonauts in Russia. And it was then produced more massively, and it was called Diadens or Senar. And there's actually a Senar cosmotic which Nick Dogris uses, and it's on his website, and he uses that for chronic pain. And I actually introduced him to that sort of smaller device originally when I visited him in Bishop and did his course in Bishop. And so Nick now has this big $5,000 worth Senar cosmotic device, and it's a neurofeedback device, handheld, that picks up the dysregulation and corrects it. And very similar to what Nerida said, you can either use sounds, but you can actually hear it, and it has amazing effects on people suffering chronic pain. And it's not very well known. Most of my chronic pain patients end up with either a Senar or a Diadens machine. You can get them, believe it or not, from Amazon, or you can buy them here through a Sydney lady who charges nearly $1,000 for each device. She imports them from Russia directly. But it's not, and you know, then there's also some little infrared lights and things like that that can work as well. So when you're dealing with people with chronic pain, it's not something I would initially advise introducing some sort of magic wand, but when the person's ready for it and they have enough self-regulation strategies, you can sort of top it off with a really small handheld neurofeedback device. And I found that basically saved my sanity and saved my life in many ways, as well as all the other things, particularly EMDR, eye movement desensitization reprocessing, which has an enormous effect on, you know, regulating the brain and doing left-right brain stimulation and the anxiety release. So I just wanted to give it a little plug, not something that I would suggest anyone does, but, you know, from personal experience, when you are a chronic pain sufferer and something works, you hold back, and in the end, you tell someone.
Yeah, so Mariana, you were just holding it up, were you?
Yeah, that's the system.
Yes,
It's
very
not
similar.
device.
Yes,
There
very
it is.
similar. Yeah,
All right.
thank you.
So,
Thank you. I'm not the only gay in the village. I'm very happy to hear this. I was very careful what I say. You know?
Go see Mariana. Go see Mariana.
Mariana.
And
That's exactly what.
yeah.
Yeah.
And
Can I say, can I
you-
chime?
Go ahead.
Dana, you said something. Tell us. Yeah. tell us.
Mirjana, Mirjana, Marianne, you introduced me. I knew about it, but I'm skeptical. I go for new things, but also skeptical. And when I saw it from you, I'm using it on my arthritic wrists for about ever since you introduced, and it's excellent. So in between sessions, people could use it themselves.
Indeed, indeed. It's a portable device. It's like a lot of things that you could record on the phone. It's very important for patients in pain to have portable sessions, I think. But thank you for supporting me, because I don't want to be sounding like really,
A pleasure.
Thank you, Dana. Thank you. Appreciate it.
Okay.
I was, you say.
All right, we'll be in touch. We'll be in touch with Mirjana. No worries. Other thoughts? Okay. Well, let me talk a little bit about neurofeedback for chronic pain as I've seen it. I once had a guy who was definitely hyperactive impulsive, and this was in the early days. And I mention that because that's what I ended up training him for. But he had done his back, a car mechanic, and he ended up holding a car engine because the hoist that held the engine failed. And he just twisted his back and did a couple of his discs in his lower back. So he was taking 12 Panadine Fort when I first met him. And Panadine Fort just suppresses appetite. So he was skinny, didn't eat much of anything at all, was getting worse and worse. And we just did C4-A2 and we rewarded 12 to 15 because he was hyperactive impulsive. And I figured, okay, that's my best shot. And he basically was able to get off the pain medication. And for me, the clue is that his system generally was overactivated. I mean, that seems to me when I look back on it. And C4-A2 just calmed his system, and it also calmed that. And he definitely was able to function. Now, he smoked dope and he used dope in the end to control some of the pain, but he was able actually to function after that. And when it comes to what people talk about, like Ed Jacobs talks about this dual reward protocol. And he talks a lot about working with fibromyalgia, either at CZ-A2 or at FZ-A2. And he says, you do two rewards, you do 8 to 11 and 12 to 15, and you standard inhibits. And he says that's a very good protocol for fibromyalgia, also chronic pain. And he's big on this idea of having two rewards. Now, when I spoke to Ed Hamlin about it, he had a slightly different perspective. And he gave this view on it. He says, look, there are people who experience enormous amount of pain, but they just sort of suffer through it and don't say much. So for them, the perception of the pain is very strong. And for them, he says, I might consider P4-A2 rewarding 8 to 11. He says, then there are people who are completely undone by the pain. So the perception of the pain itself is actually happening just in front of CZ, really in the anterior cingulate gyrus. One of the functions of the anterior cingulate gyrus is what is the value or the valence of this pain that I'm experiencing, and the evaluation of that pain. So he said, so for people who really are undone by the pain, maybe F4-A2 rewarding, and he said 8 to 11. And then he says, you know, maybe just go to the Bermuda Triangle on the right side and F4 - P4, rewarding 8 to 11. And when you're considering those protocols for chronic pain, those are things that I would consider. And then there are other kinds of pain where calming is actually not on the cards. And we had, I think, it was just a while ago, I've got her name down here. It's, Katie mentioned activation. And the last thing I want to talk about just briefly, when Jay Gunkelman talks about migraine, he's always talking about blood flow underneath the brain. And his view is that there's a problem with the blood flow and that we have to train the temporal lobes at 12 to 15 hertz or lower. That can be because they just had migraine from birth, or it's genetic, or that they've had a car accident and post-trauma headache showing up at T5 and T6. And so his view is that you never want to train the temporal lobes above 12 to 15. And because it's a blood flow issue. And I was having a discussion with Mike Cohen in America a while ago, and Mike runs a clinic and he knows more than I do about neurofeedback. And so he goes, well, you know, it's sort of interesting you talk about 12 to 15. He says, for people who seem to be a bit on the underactivated end, so not high energy folks who have migraine, I start at 12 to 15 at T3 minus T4, and then I go up and works fine. And so for me, it's like, oh, okay. So I wonder where Jay's theory about blood flow and him saying you don't train above 12 to 15 in the temporal lobes if there's an issue with migraine. And clearly, Mike Cohen just goes, no, that's what I do. So I was looking for alternative explanations, and there were at least two other explanations that I saw in the literature for migraine. And one of them is that the, what do they call it? Well, first of all, there's a hormone thing. Women who experience migraine around the period, it's a change of female hormone can induce migraine. That's not necessarily blood flow. And the other one is trigeminal. That's the word I was looking for. The trigeminal arterial system. So we're not talking about the trigeminal nerves, we're talking about the trigeminal arterial system, which actually gets blood supply into the meninges. And they were talking, I mean, in the literature, they're just talking about that being a cause of headache. So for me, it's like, well, we may not understand the cause, but for some people with migraine, the reward frequency can go up above 12 to 15. So that's just another thought. We've got 10 minutes till finish now. If there's anything anybody wants to bring up or talk about or ask a question about something else, welcome to. Otherwise, we get a break.
This is brilliant, Moshe. That's why we have Moshe in this field, you know? We all tell stories and then he summarizes and gives us something that is much more sophisticated. Moshe, you are a legend.
Thank you. Don't know what I said, but that's okay. Okay. So I think I can pass this back to, might be Shayla or whoever's up for our next presenter or whatever. Thank you all very much.